Everyone. I want to thank the Kunle Azan I Foundation Academy for the opportunity to share this my small presentation with everyone. I appreciate everyone that has also made time to listen to this. So OCT has been a passion for me since it was introduced in I think about year 2002 was when the first series of OCTs came out. Let me first start with my disclosure. I have no financial interest in this topic. Information for this presentation is from different sources. Not all the slides are mine, but there are quite a number from daily clinics, patients, different webinars, word rounds, unpublished and published articles. So I give credit to everyone. Again, a note of caution, OCT is meant to be used as an investigational tool. We don't treat OCT scans, we treat patients. So even though we'll say this is a pathognomonic feature, we still need to do a thorough, take a history, thorough examination and do other tests to further confirm our diagnosis, and we should take note that we treat patients and not OCT scans. So in the analysis of the retina over the years, we as ophthalmologists and particularly retina specialists, we have the advantage of being able to view the retinal tissue directly, unlike other people who really have to, like, you don't look at the heart directly, you have to do a lot of angiograms and everything to be able to see it. But we can see the retina directly, and as a result of that, that gives us a lot of advantage to analyze disorders of the retina. And over the years, we've looked at, we had a scanning laser polarimeter, often called the GDX. Then we also still do have the confocal scanning laser ophthalmoscope. And then the OCT has been phenomenal since it was introduced. I remember the GDX when we had it. It actually provides good RNFL thickness values. It has a large database, and we can also assess progression. But the problem with the GDX then was it has a lot of atypical pattern as a result of birefringence, and then it was very difficult to compare cases. And then in some cases, like in high myopia or where there is a lot of retinal atrophy, we do not get that much information. So the OCT started off with the time domain, and it was very beautiful for us. Then it provided cross-sectional images, was useful to calculate the RNF thickness and the cross-sectional scan for retinal pathologies. However, there was a lot of issues with the speed of acquisition of the scan. It was very slow, and it had limited data for retina, and also the macular maps were not so easy to interpolate. And then the speed of the time domain OCT was about 400 A scans per second. Unlike the newer sessions now that we have, the Fourier domain, or sometimes referred to as the spectral domain OCT, it takes as many as 26,000 A scans per second compared to 400 A scans per second that the time domain OCT was taking. So we're able to have a lot more detail of the retina. Let's not forget that the technology is based on the Michelson's interferometry. So, like I said, in 1994, we had the initial prototypes of the OCT. The OCT in about 1996, and OCT 2000. 2000 had the Stratus OCT, and with that we were able to begin to see a lot of the retinal tissue. And by 2006 came the Fourier domain OCT with a lot of detail. And by 2014, the OCT angiography, which is the fourth generation of OCT, came to place. I'm hoping that at my next lecture, I'll be able to talk about the OCT angiography. So OCT captures not only tissue structure. Now we're able to get a lot of function from OCT, and we're able to look at the retinal blood flow. Like I said, that is with the OCT angiography. On the OCT, the Fourier domain, I think it's the Optoview that call their own the Fourier domain. Zeiss and the others call the spectral domain, but they're about the same generation of OCT. So we're able to actually segment the retina, look at the inner thickness, the full thickness, look at the outer retina, different from the inner retina, and look at the topography of the retina. And it's a lot very useful. OCT now, those tissues, as we all know, they are not colored. So the colors that we see, they are false color codes, and they are used to represent the nature of the tissue that we see. So when you see large reflections, they are represented by warm colors, red and yellow. When you see mid reflections, they are reflected by cooler colors, green and blue. And then where there's no reflection, like if there's fluid, it's usually going to be black.
Sorry.
Hello? Can you hear me?
We can hear you now. You were muted for a little bit.
Oh, okay. Sorry. So I said the colors that are represented on the OCT, they're actually false color codes. Of course, the tissues are not red, yellow, or blue, but those color codes are used to represent different density of structures. Like the highly reflective structures are things like neovascularization, cottonwood spots, hard exudates, asteroid hyalosis, nevus and fibrous tissue, whereas low reflective structures are cyst, fluid intraretinal cavities, diffuse edema, and also the fluids that we see in exudative detachments. So this is where OCT is very good, and I like us to go a little back into our basic medicine and our understanding of the retina. Right back in medical school, we were taught that the retina has 10 layers, and so we can actually identify all the 10 layers on the OCT. So the 10 layers, if we go through it in our minds again, you have the internal limiting membrane, you have the nerve fiber layer, the ganglion cells, inner plexiform layer, inner nuclear layer, outer plexiform layer, outer nuclear layer, outer limiting membrane, the rods and cones, and the pigment cell layer. That's the RP, the retinal pigment epithelium. So we are able to actually see all these layers on the OCT. All of them are fully represented, and I'll go through it in a way that it will help us to remember it. So when we look at this image, the first one we are going to see, the first line here is the internal limiting membrane. Then after that, we have the nerve fiber layer. Usually, as we remember, the nerve fiber layer is going to be thicker as it goes through the optic nerve. And this is also one of the ways where we can identify on a scan if it is a right eye or it is a left eye. And immediately after that, we have the ganglion cell layer. Then we have the inner plexiform, the inner nuclear. Then we have the outer plexiform and the outer nuclear. Then after that, we have the external limiting membrane. And in this outer part of the retina, the outer retina, there are 4 hyperreflective bands. And so as a summary to help us, when we look at this, I did just an analysis there, and you find out that first of all, nuclear layers are hyporeflective. Now, the terminology used here is hyporeflective when they are darker and hyperreflective when they are lighter. Note that I am also using the black and white and not the color. In order to see detail very well, the black and white is actually a better way to see detail of the retina on the OCT rather than the color. So the outer neurosensory retina, that's the nerve fiber layer and the inner plexiform layer, they are visible. After you see the nerve fiber layer, you see a hyporeflective one, which is the ganglion cell layer. Then you see the the hyper-reflective layers, outer plexiform, inner plexiform, then the nuclear layers are hypo-reflective. And we have those other 4 layers that they are extremely important in the analysis. Now, there's a terminology group in 2014 that tried to standardize all the terminologies, because there were a lot of initial names that were given to these layers at the onset. So one of the things was the inner segment, outer segment junction, which is now called the ellipsoid zone. Now, I want to point out those 4 hyperreflective lines that are present in the outer retina, and these are them. Starting from the inferior or the most outer one, that is the retinal pigment epithelium. Then you have the cone segment, cone outer segment, or the intermediate line, or the vitreous membrane. Then you have the inner segment, outer segment junction, which is now referred to as the ellipsoid zone. And then you have the external limiting membrane. So we've gone through in the inner retina, we've seen the areas that are hyper-reflective, and in the outer retina, we've seen the hyper-reflective bands. This anatomic presentation is the basis of all OCT interpretation. And having an understanding of this basic anatomy is very, very important. I've spoken about the terminology, but today we'll not be really emphasizing too much about the terminology, and we'll be looking at clinical cases. So we're going to look at a series of clinical cases, a series of disorders based on these 4 areas. We are looking at the vitreoretinal interface, the intraretina, the subretina, and the sub-RPE. So the vitreoretinal interface has really come alive with the OCT. We're able to see disorders that hitherto we had little understanding about, but with the OCT, especially with the Fourier domain and with the newer quality, higher quality OCTs, we are able to see better. So 2 disorders, well, basically 3 disorders, one that we knew very much about, and some that we knew quite little about have now come to play. So we talk about vitreomacular adhesions. This is when the posterior vitreous face is still adherent to the macula, with the vitreous having separated around the adhesions without any visible deformity of the macular contour, as you will see here. Whereas the vitreomacular traction, VMT, is when the posterior vitreous face is adhered to the macula with vitreous separation at the adhesion, with any change in the macular contour at the adhesion site that could be attributed to the traction. And so that's the vitreomacular traction, as different from vitreomacular adhesions. And from a lot of studies, we found out that you can have different ways in which these adhesions look like. Some of them are V-shaped, some of them are J-shaped, some of them are broad, some of them are C, the focal type, and you also have the U type. And these particular types are very representative of what we might expect, a likelihood that we have, because about 10% of the V type or the U type, as seen here, the patient tends to eventually develop full thickness macular holes. So those are things that we learned from the OCT. And you can see this vitreomacular adhesion. You can see this has already formed a cyst. There's a cystic change on the surface of the retina there. And then you can see vitreomacular traction. You see there's a deformation of the fovea contour, and even the lines, the outer retina and the inner retina are affected. You can see the cystic spaces within the retina here. Now, as a result of traction, a number of things can happen. There could be formation of sort of cysts, and if it's large enough, we call that cystoid macular edema, and we look at them from many disorders. This is a diabetic patient who started off with, you can see the fundus picture, that's a cotton wool spot here. This is the red free light, that is a cotton wool spot. You know, in the red free light, it shows white, and then you can see the vitreomacular traction here, and at this point, he developed macular edema, and we started the patient on anti-VEGF injections. And after 3 injections, the macular edema has resolved significantly. Of course, like I said, we are not managing OCT scans. This is a patient, and you have to pay attention to other management, glycemic control, and other things to ensure that the patient does well. Again, in sickle cell retinopathy, we have some papers that look at the series of vitreomacular interface disorders in eyes with proliferative sickle cell retinopathy. That's another thing that we're able to do. At a point, we were introduced to ocriplasmin, and ocriplasmin was said to be able to resolve vitreomacular attraction, and after a number of studies, particularly the MEVI study, the width factor was defined, and that is the base diameter minus the minimum linear diameter in microns. And when you look through the MEVI study, you find out that the smaller the width factor, the more likelihood that ocriplasmin is effective. Unfortunately, ocriplasmin has not really made that breakthrough because of some of the challenges with the injection. And so let's go to posterior vitreous detachment. This is a common disorder that we see. It has been staged through 5 stages. Stage 0, no PVD. Stage 1, when it's incomplete with perifoveal PVD. Stage 2, perifoveal, but in 3 quadrants. Stage 3, incomplete PVD over the area of the disc, but it's already detached from the perifoveal area. And in stage 4, the PVD is complete with a separation from the optic disc, and that is when we see the wise ring, and wise rings can either be complete or incomplete. This is very obvious on OCT. We even see the earlier stages where there's vitreous liquefaction, what we call syneresis, what we call synchisis, and vitreous contraction, what we call syneresis, that usually precedes these changes that eventually lead to posterior vitreous detachment. And of course, you can see the vitreous floating over the area of the fovea when the vitreous has been fully separated. And when it is still adherent to the area of the disc, when there's vitreopapillary adhesion at stage 3 PVD, we can see. So the OCT is very good in analyzing PVD, and it can give us a lot of details. And when the wase ring is separating, we can actually see the traction bands going on there. In the International Vitreomacular Interface Classification, it was, I think, 2013 by Duca JS and et al. And co. And so they were able to give us the various classifications, sub-classifications of VMA and VMT and macular holes, and they defined large holes as greater than 400 microns, and either they are isolated or concurrent. All these things were done using the OCT. Now you can actually use your OCT to measure the base, to see how big there are calipers on the OCT that can be used to measure how either this is a focal or a broad based, and the cutoff point is the disc diameter, which is 1,500 microns, as we see here in the international classification. So in the interface, retina interface, we also have epiretinal membranes that we see a lot better on OCT. Of course, they have grade 1, grade 2, and grade 3. Grade 3 is when there's marked obstruction and distortion of the underlying retina and vasculature, what we used to call macular pucker. And so on the OCT, we're able to see a lot of that. We're able to see also lamellar holes. And as they are, of course, we all remember modified gas classification of holes, full thickness holes, 1A, 1B, stage 2, stage 3, and stage 4, where there's greater than 400 and there's complete vitreous separation. So, of course, on OCT, it has become an exceptional tool for the evaluation of macular holes. We can look at each of the stages of the macular holes from stage 1 to stage 2 to stage 3 to stage 4. We can also do a lot of measurements that help us to assess the probability of closure of the macular hole. So we have the hole form factor, macular hole index, the tractional index, and it's based on measuring. I said earlier that we can use the calipers to measure each of these lines. Usually the hole height is from the peak to the base, and then you have the base diameter, which is here, and then the minimal linear diameter here, and you have the arms on the right and on the left, and all this can be measured on OCT. For some of our studies, we use the hole form factor and a C over D. This is, sorry, C plus D over A. A is the base diameter, B is the minimum diameter, the left arm and the right arm. And when the hole form factor is greater than 0.9, there's a better likelihood for closure. Now, this was very important to us when we were doing the traditional macular hole surgery. We need to be able to tell patients that these are the prognostic factors for you. With the newer techniques that we do now, we do inverted flaps, we do a number of other techniques. It's really, I wouldn't say that it's still relevant, but it's not as relevant as it was before. Another thing we're able to do on the OCT, we're able to evaluate the outer retinal reconstruction after macular hole surgery. This is extremely important. Of course, what we're looking at is the ellipsoid zone and the external limiting membrane. Maybe they were reformed. This is a macular hole. You can see stage 4, full thickness. No.
Sorry, Dr. Berilo, please, they're asking that, can you use your cursor to point when you are describing?
I'm actually using my cursor. Can they see it? Can you see it?
I cannot see your cursor moving, sir. I don't know if other people can see your cursor moving.
Okay, but I can see it. I don't. This is.
I can't see it too.
Okay. This is. I'm actually seeing it. Frances, please, can you ask IT to come and help me while I continue?
Okay, sir.
We are not seeing it.
You can't see the cursor, but I can see it. Okay, on the upper left, you can see a stage 4 macular hole. And on the upper right, you can see this is the macular hole after closure. What I said the OCT helps us to do now, I spoke about the hyperreflective bands, and you can see that they're in the center, in the subfoveal area, there is the ellipsoid zone is not fully formed. You can see it's like there's a small box that is missing here. When you compare it to this second one on the lower part, where the ellipsoid zone is fully formed. So when the ellipsoid zone is fully formed, we consider that as a complete outer retina reconstruction. And this is very important in macular hole surgeries because it helps us to know, and it's a predictor of how much visual recovery the patient will get. And these are things, sometimes you do a macular hole, you look at it after surgery in every way, it is completely close to you. The patient's vision is 612. And the patient says, no, I mean, something is missing. Sometimes there's a missing. But you are looking at the hole with your eye. You've done everything possible. Everything looks perfectly close. And OCT usually tells us what is going on. And like we can see in this patient, I remember these are my patients, both of them. It has a full closure. The patient was a myope. His vision was 612, but he kept complaining of a small central scotoma there, and I was able to explain to him that it was because the outer retina was not fully reconstructed. And usually what happens over time, especially when you are using the inverted flap technique, is that there's continuous outer retina reconstruction after the macular hole surgery was successful. And probably if we do this at about 6 to 9 months, you will see that the outer retina has fully been reconstructed. So this is another of our patients, post-trauma, a young man from the military that had a traumatic left eye. Again, one of the challenges we had when we started doing inverted flaps was that sometimes you could see some parts of your flaps, they are flowing. This is 1 week after surgery. But as you see, as the healing goes, okay, so I can say A is the macular hole, B is the fundus photograph. You can see the coloretinal scars formed. C, you can see that there's a flap from the ILM, because what I did for this patient was an inverted flap surgery. You can still see some part of the flap floating on C, but on D, which was about 6 weeks after surgery, this patient has 6/6 vision. 6/6 vision, full reformation of all his outer retina. Because of this scar, you can still see the scalloped appearance of the RPE and the scarring. But when you look at the foveal area, you can see that there's full outer retinal reconstruction. And like I said, this patient has 6/6 vision. So OCT is invaluable in assessing these patients, and it's so much has helped change a lot of things. I was going to ask so many. Let me see who wants to guess what this is. David, are you online? David Ogbonaya. I said I will ask you a question yesterday. Are you online?
Yes, sir.
So what is this? You can see this line, this in the first picture up. Actually, on both of them, you can see a hyper-reflective line above the fovea. What do you think this is? Okay, so not to waste time. What is it?
Retina membrane.
Okay, so it's not an epiretinal membrane. This is a patient that had a retinal detachment surgery, and what we are seeing here is the reflection of the silicone oil. So that's a silicone oil retina interface. And one of the things why silicone oil has remained has remained used by many surgeons is that despite the retina being flat and everything going on well, there's an interface between the silicone oil and the fovea that still allows exchange of nutrients and sort of, let's say, it allows the fovea and the cells to continue to have metabolism without being obstructed. This is very different from perfluorocarbon. If you put perfluorocarbon, you will not see any interface. It will rest directly on the retina, and that's why we don't leave perfluorocarbon in the eye for long, because it does not allow the retina in quotes to breathe. Now, don't forget, we have done the vitreoretinal interface, we are going to intraretinal. Very important, diabetic retinopathy. We should be able to we use OCT to assess the stage of the retinopathy, to assess treatment, especially when we are looking at macular edema, if the edema is resolving and if things are getting better. But the key to the assessment is what we see. This picture is taken from Kansky. I'm sure most of you recognize it. It was still calling it background diabetic retinopathy. Sorry, it was my own Kansky. No, now I know they call it non-proliferative. It's called non-proliferative and proliferative, like I've put here. And on the first one on top on the right, you can see the location of the lesions here. So you can see the nerve fiber layer is where the flame-shaped hemorrhages are. And you can also see that the cotton wool spots are there. So you can see the dot and blot hemorrhages that they are in the outer plexiform layer. So this is actually what you are looking out for when you do an OCT. So in the OCT, you see these cystic spaces, you see this hemorrhage. You know that this hemorrhage is not a nerve fiber layer hemorrhage, it's not a flame-shaped hemorrhage. I mean, this is actually a cystic lesion. When you look at the exudates are usually in the outer plexiform layer, and you can see it there, and it causes what we call a shadowing, and that's the lesion, the part of the retina below is not seen well on the OCT because of the exudates that blocks transmission of the lesion. So again, look at this. We say cotton wool spots. They are hyper-reflective defects in the nerve fiber layer, and you can see a cotton wool spot here. Hyper-reflective lesions in the outer plexiform layer are hard exudates. You can see them. Hemorrhages are hyperreflective spaces within the retina. Now, so one thing I also say, because it's not every time you are able to accurately identify the position of the lesion, to accurately say this is the outer plexiform, this is the outer nuclear layer. One other thing, well, a shortcut is to be able to, you should be able to identify inner and outer retina, so that you can say this is going on in the inner retina and this is going on in the outer retina. But the best thing is to be able to identify the exact position of a lesion that you are seeing, because that is what gives away the diagnosis. So diabetic macular edema, of course, we know that there are many types. You have the focal macular edema, you have the diffuse macular edema. This is diffuse macular edema with subretinal fluid, and this is cystoid macular edema. You see the multiple cystoid spaces. Again, this is a diffuse macular edema with cystoid spaces and subretinal fluid. Usually, when you see this subretinal fluid with cystoid spaces, these cystoid spaces used to be called spongy appearance. So whenever you see these cystoid spaces with the subretinal fluid, many times these eyes respond well to anti-VEGF. And we will look at other presentations and of retina. We'll look at the treatments and the regime, the dosing regimes for anti-VEGF, because I think the place that most people make mistakes is the dosing regimen for anti-VEGF. So we are able, of course, on OCT to define which type of edema we are dealing with, and that helps us to know the treatment. When it's proliferative, of course, you can see this is tractional retinal detachment. This is the RPE, and there's a separation of the RPE from the neurosensory retina. This is a lot of fluid. It cannot just be cystoid macular edema. This is a tractional retinal detachment. And then for the new vessels, you can see the loops. You can see the loops of hyperreflective blood vessels protruding into the retina. And it's easier to differentiate from IMAs, because IMAs don't protrude into the retina. IMAs are intra-retina, and they are not visible outside the retina, whereas neovascular loops are hyperreflective and they are protruding into the retina. That's actually how the process of a detachment starts. So, like I said, we use OCT now for the monitoring of treatments, and we're able to look at patients, diabetic macular edema, and follow them up and see if they are getting better, or if they are resistant to anti-VEGF. So let's talk about macular telangiectasia. This is something also that I see often, and quite a number of us miss it. But it's very important to know that macular telangiectasia, the abnormal vessels originate from the deep vascular plexus. They are not on the superficial. They come from the deep, and then they eventually affect the whole retina. So they start from the outer retina and come towards the inner retina. And there's what we call the ILM draping, where they have become cystoid all through the retina, and it is only the ILM that is left on the surface covering them. As you can see in this, my patient, the picture down and left of the OCT, you can see that there are cystoid spaces both in the outer retina and the inner retina. The one in the inner retina, you can see there's just a small membrane on top that is left, and that is what is called the ILM draping. It is almost pathognomonic of macular telangiectasia. I said almost pathognomonic because there are some other things that can give it. But like I said, you don't just look at an OCT in isolation. You have to look at the presentation and how the patient is. Don't forget the classification into 3. Group 1, unilateral parafoveal telangiectasis. Group 2, bilateral parafoveal. And group 3 is also bilateral with retinal capillary obliteration. So this is MacTel. MacTel, you can see the ILM draping. ILM draping here is quite a common thing that we see in our clinics. Like I said, this is OCT angiography. You can see these are on-face images, unlike the ones we've been looking at that are cross-sectional images. This on-face image shows us that when you look from your right, the most extreme on the right, you can see that is the choroidal plexus, and you can see that the lesions are actually more on the choroidal and the outer retina than when you come to the superficial. It's not so pronounced as you will see in the outer retina. So that is MACTEL. Another thing that we see, although it's more common among Asians, is what we call myopic foveoschisis. We've seen in highly myopic patients where the fovea area develops something like a schisis, like schisis cavities, like you can see in these photos on the left, and you can see the OCT, you can see the cystic spaces all over in the outer retina, and usually what you see is that there's a split involving the Henle's layer, that's the outer plexiform layer, showing a thicker inner layer and a thinner outer layer. So this is the inner layer. The inner layer is the one that is closer to the vitreous, and it is thicker when you compare it to the outer layer. When this is going on in the area of the fovea, it is referred to as foveoschisis. And Ikuno and colleagues classified foveoschisis into 3 types: the foveoschisis type, the fovea detachment type, and the macular hole type. And all these 3 are able, we identify them on OCT, and each of them respond differently to different management techniques. And especially if you are going to do a surgery for them, there are different techniques that you do for each of these stages. Central retinal artery occlusion is another vascular disease that we see. As you can see in the picture on your right, you can see that this patient probably has a ciliaretinal artery, but the other areas is fully ischemic. And what you see is that there's, in the acute phase, what you see is that there's an increased reflectivity and thickness in the inner retina and a corresponding decrease in reflectivity in the outer retina. So the OCT image that you can see here, you can see that there's an increased reflectivity in the inner retina. It's almost uniformly white, whereas the outer retina is almost uniformly black because there's a decreased reflectivity. But as this goes from the acute phase to the chronic phase, so they both begin to have a decrease in reflectivity, both of them, and the edema goes down. So let's go to the outer retina. And one of the more common lesions that we see in the outer retina is the central serous chorioretinopathy. So many times I've had to discuss with my fellows and my residents about CSR. Now, the position of the CSR is usually fluid accumulation between the RPE and the neurosensory retina. So there are cystic spaces. Unlike if this was a retinal detachment, it will continue to the periphery. But you can see this is a localized cystic space. Of course, we know that fluorescein angiography will show us either an ink blunt or a smokestack appearance, but the OCT gives us a lot of detail in the cross-sectional view of the eye. So, drusen. Drusen are things that have been well investigated, and they are best defined by the OCT compared to other modalities. In the ARED study, drusen were classified into 3. Small drusen less than 600 microns, intermediate drusen between 63 and 125 microns, and large drusen greater than 125 microns. And so you can see the small drusen here, and you can see the intermediate drusen and the large drusen here. And like I said, you can use a caliper and actually measure the size of the drusen if you are in doubt as to what it is, what the size is. So small drusen are less than 63 microns, I've said that, and they are considered a normal aging process. They do not represent a significant risk for progression to advanced AMD. So drusen can also be classified based on their location, either they are reticular or they are cuticular, and usually the reticular ones are located above the RPE and they are associated with progression to advanced AMD, unlike the basal lamina or the cuticular. So you can also use this, you can use the size of the drusen, you can use the location of the drusen to be able to identify the risk of a patient to develop advanced ARMD. The ARED study, again, they gave us these categories based on the size of the drusen, and we're able to give prognostic values to each of the categories as seen and represented here. So patients in category 1 have less than a 2% risk of developing exudative changes in 5 years, and the risk in category 3 is approximately 25% in 5 years. So again, we use this a lot in a lot of clinical studies. So I want to talk about pigment epithelial detachments. I hope I'm not moving too fast. So pigment epithelial detachments are upward displacements of the RPE by material between the RPE and the choroid. They may be seen in isolation or in association with ARMD. There are different types of pigment epithelial detachments based on OCT classification. We have the serous PED that are dome-shaped with well-demarcated borders. We have the drusenoid PEDs that may have regular or irregular borders, and they vary in size from small to medium and large. We have the vascular PEDs, and the content is often highly reflective. And we have the serosanguinous PEDs that are most often associated with polypoidal choroidal vasculopathy. So let's look at some of them. So PEDs, you have the drusenoid PEDs, you can see this small drusenoid. You have the serous PEDs, you can see they are uniform, and the content in the PED is serous, is dark. On OCT, you can see the focal RPE detachment with adjacent subretinal fluid. When you see adjacent subretinal fluids to PEDs, you should begin to consider choroidal neovascular membranes. And then you can see this serosanguinous RPE. Like I said, this most often happen in polypoidal choroidal vasculopathy. So again, you see PEDs. This is this one with a temporal RPE detachment. These are large drusenoid PEDs. These are small and medium-sized drusenoid PEDs. This is a vascular PED. This is a fibrovascular PED with subretinal fluid. And again, by fibrovascular PEDs, you need to consider choroidal neovascular membranes in association. So isolated PEDs here. These are Nigerian patients. These are our patients. So you can also see the drusenoid PED here. And so it's very important to be able to make a good distinction between PEDs and central serous chorioretinopathy. Like I said, the fluid in central serous chorioretinopathy is between the neurosensory retina and the RPE. This really looks like somewhat exudative fluid, but you can see that there's a hyporeflective area here that shows the less exudative fluid, and on the upper one you can see it's written wet exudative AMD there. So you can see the PED, fibrovascular PED with associated subretinal fluid, and I said in most cases like this is a choroidal neovascular membrane associating it. Of course, you can know that this is a serosanguinous PED in a patient with polypoidal choroidal vasculopathy. Down to the left, you can see the fluorescein angiography picture that shows the hyperfluorescence in the area of the polyps. The best one to use to assess this are usually in the cyanin green angiography, but on the OCT, we can see a lot of information, especially this serosanguinous PED. And this is the same patient afterwards. He had 8 injections. This is in the middle. You can see the PEDs are going down, and this is as his last injection after having 8th injection. He's still under close observation, but you can see full restoration of the retina anatomy, no more PEDs, and the RPE and all the ellipsoid zone, they are all restored. Patient's vision here is 6/6, and you can also see this is OCT angiography and on fast image of the fovea, leaving no residual PEDs. So sometimes there are pigment epithelial detachments, what we call idiopathic pigment epithelial detachments, that can happen in young individuals. As you can see, if you look down, there are 4 images here, but the one down and left, you can see this looks like a cystoid lesion in the area of the fovea, but what we can see here is a PED. and this is an isolated idiopathic PED in a 35-year-old man. We just need to observe his vision was 6'9", and so we keep observing him. And on the upper side, you can see this drusenoid PED in a relatively older patient in his 50s. So also we can see advanced geographic atrophy. You can see the thinning of the retina in the area of the fovea, as is seen in this advanced geographic atrophy. We can also use OCT to classify the type of membranes that we see: type 1, type 2, type 3, and type 4. Type 1 is the occult one and is usually sub-RPE. It typically corresponds to angiographically occult choroidal neovascular membranes. And type 2 is the classic. Differentiating between a classic and an occult was very important for us when we were using lasers and we are using a lot of PDT to treat choroidal neovascular membranes. But these days of intravitreal injections, either it's classic or it's occult, we use anti-VEGF to treat them. We should look at type 3, which is the intraretinal retinal angiomatous polyp, RAP. Now, the RAP is different because RAP originates from the retina and it grows towards the choroid, whereas choroidal neovascular membranes originate from the choroid and they grow towards the retina. And type 4 is the mixed type, which used to be referred to as the minimally classic, which has type 1 and type 2 and is located below and above the RPE. So occult membranes, and we have this study that we also did some years ago when we were using TTT, and I said then it was very important for you to differentiate between classic and occult membranes, and this was a patient with a classic membrane. The OCT is so excellent in analyzing these outer retinal disorders that it gives us a lot of information. We can look at what is the RPE component, what is going on below the RPE, and how we don't just see that a space is hyper-reflective, but we can see in cross-section what is actually going on. And this is type 2 choroidal neovascular membranes, and disciform scars too, as they form, we can see them there. This is again OCT angiography. It gives us, you can see on the upper part, you have the superficial vascular. It's been long that it's been postulated that there are two major vascular plexi in the retina, the superficial and the deep. But not until the onset of the OCT and the OCT angiography can we really image them different from each other. In the earlier forms, there was what they call the projection artifacts, which have been improved in the newer forms of the OCT angiography. And we can see, like in this individual, we can see that a lot of the activity is here in the choroid. It's a choroidal neovascular membrane, and then it grows into the outer retina, into the deep, and then you can barely see it in the superficial retina there. So OCT angiography will be another topic later. RPE hypertrophy, we can also see that a lot. We can see the pigment clumps within the area of the retinal pigment epithelium. We can see the pigment clumps there. For coloretinal scars too, we can see the whole compromise and the thinning out of the retina. This is a patient with treated toxoplasmosis. You can see the active toxoplasmosis on your upper left. You can see that same enhanced hyperreflective outer retina and a reduced reflection in the hyperreflective inner retina and a reduced reflection in the outer retina. I couldn't get the OCT image for when it clears up, but what usually happens is that there's a complete this hyperreflective inner retina becomes less reflective as the scar becomes less dense. And so you also can differentiate between nevus and melanomas on the OCT. Melanomas are elevated and they have extensive blockage of OCT signals. They are shaggy in appearance. And you can see the loss of the external limiting membrane, and they can also be associated with subretinal fluid when you compare it to nevus that are usually just flat and atrophic. So inherited disorders are something that we also use OCTs to look at. Quite a number of inherited disorders. I will just look at a few. You have the central areolar choroidal dystrophy that has, what it shows is that there are hyperreflective defects due to loss of the RPE and the inner and the outer retina. Retinitis pigmentosa, I know we all see a lot of that. In the center, you can see the multifocal ERG that shows attenuation of all the waves in all the quadrants. Initially, attenuation will start in the mid periphery here, but this is an advanced RPE as you retinitis pigmentosa patients, as you can see, complete attenuation of all the ERG. This is a multifocal ERG, all the multifocal ERG waves in every of the patient's quadrants, and the OCT shows a marked retinal thinning in both the inner and outer retinal layers. You can see it there on your left and on your right. And because of the thinning of the retina, you can see an enhanced reflectivity of the choroidal structures. You can actually make out in this patient his choriocapillaries because there's a marked thinning. This happens in advanced RP, retinitis pigmentosa, and in other disorders that cause atrophy of the whole retina. Best vitelliform dystrophy, the vitelliform material can also be located within the retina, and it's usually in the outer retina area. Cone dystrophy is sporadic, often affecting individuals. Its presentation is in the first to third decades. Individuals are usually very young when they present. This bullseye maculopathy is a lesion that is seen in a number of other disorders, and also we see in Stargardt's disease. I want to talk about using the OCT for the optic nerve head. The number of things we want to differentiate are significant, but we want to differentiate between a pseudo disc swelling and a disc swelling as a result of raised intracranial pressure, what we call the papilledema. So in the pseudo disc swelling, let's look at the papilledema first. So you see that the contours, the internal contours over the area of the disc. Again, when you are taking this image, the line scan should be over the disc so that you can be sure that you are getting the true picture. So you have smooth internal contours, and then what we call the lazy V pattern. You can see this edge, there's a lazy V pattern here, and it's almost pathognomonic of papilledema. Unlike pseudodisc swelling as it will happen in hyperopia, you can see that there are smooth edges internal, but there's no V-shaped pattern at the edge. And this helps us to differentiate between papilledema. The lazy V pattern is because of fluid that is tracking in to the head of the optic nerve from, the anatomy, from the subarachnoid space. So you can actually see that area, that edge of the leakage, and that's what shows the lazy V pattern. Optic nerve drusen don't have lazy V pattern. They don't have smooth edges, but they have bumpy internal contours. Of course, you can do a red free light and autofluorescence too for optic nerve head drusen. So optic disc maculopathy is another thing that we see well on the OCT. If you look at the image on your right, image D, it's a cross-sectional area. You can see the disc. You can actually see the optic disc pit there. And sometimes there's a leakage of this disc pit and it leads to a maculopathy. And that's what you can see in the splitting of the macula, the neurosensory retina from the underlying RPE. And this is one of the other things we can see. So briefly, let's talk about hydroxychloroquine toxicity. Okay. Okay, my time is almost up. So, okay. Okay, hydroxychloroquine toxicity. We know. I mean, these are patients. I was with the rheumatologist, and they really asked me a number of questions on this. These are things that we need to know because patients now they are preferably put on hydroxychloroquine, and it's a metabolite, and it has a longer half-life. It tends to deposit in melanin, and it results in bullseye maculopathy. What we see on OCT, I'll just go straight. You can see the fundus picture and the dense ring scotoma that is seen on visual fields. What we see on OCT is what they call the classic flying saucer sign. And that, what it shows is that there's a loss of the ellipsoid zone in the perifoveal region. And as a result of that, there's also a thinning and loss of parafoveal tissue. So perifoveal loss here and thinning of parafoveal tissue, and enhancement of the central foveal, subfoveal space, and this makes the appearance like that of a flying saucer. That is why it is called the flying saucer sign. Now, the important thing is to catch it before the flying saucer develops, because at this stage, the patient will already be having visual defects. So serial OCTs is one of the things that is recommended for management of hydroxychloroquine. You also do visual fields and also ERG to be able to catch it earlier than is expected. White dot syndromes, it's very important. I will talk about one of the white dot syndromes because my time is almost up, which is very important that I think, so I'll just talk about multiple evanescent white dot syndrome. As the name indicates, the appearance of the dots is limited in time and may not present when the patient consults. This is when you see a patient, usually they are in their third and fourth decades, and up to 50% of them will present with a preceding flu-like fever, fever, a flu-like episode, and it is often a unilateral disease. It affects young to middle-aged adults, is predominant in women, and can be seen in myopic patients. It's best diagnosed with ICG, but the OCT gives us a lot of information here. Visual loss can be very profound, as these patients are going to show you. Unilateral presentation, vision dropped within a week to hand movement in the left eye, and you can see these cystic spaces, multiple cystic spaces within the retina that is seen in this case. You can look at this on your left. You can see the right eye, and down is the left eye. You can see the multiple whitish lesions. That is why it is called multiple evanescent white dot syndrome. Now, the interesting thing about this syndrome, first of all, this patient was sent to the rheumatologist. They did an ESR for the patient. ESR was elevated, I think about 36, and every other test was negative, all because there are a number of disorders too that can present like this, but every other test was negative, and so we manage the patient conservatively. Now, the truth about multiple evanescent white dot syndrome is that it gets full recovery without treatment, and that's what happened to this patient. Full recovery, vision is back to 6/6. However, you can see those areas where the multiple white dots were, they have formed hyper pigmented area of fundus, but you can see the OCT, there's full recovery of the inner and the outer retina. Ellipsoid zone is reformed, RP is reformed, and it often does not reoccur. If it reoccurs, then you have to think it's probably the choroiditis, multifocal choroiditis is what you think is going on. So you can also use OCT to differentiate between TB and sarcoidosis. In summary, OCT as a new investigation tool for retina has become a mainstay in our diagnostic and therapeutic process. It has become paramount that ophthalmologists understand its use and are able to follow this rapidly improving technology for the benefit of patients' care. Newer modalities like intraoperative OCT, OCTA, wide field OCT, SSOCT, Doppler OCT will be discussed in subsequent lectures. Thank you for allowing me to take your early morning on a Wednesday like this. I appreciate everyone. I hope I've been able to pass across some important information. Thank you for listening.
Thank you very much, Dr. Derilo, for this wonderful lecture on advanced interpretation using OCT. If you have any question, please type it in the chat box or raise your hand. We have a question from, I think that should be Dr. Elata. It says, thanks, sir, for the nice presentation. And the question is, sir, how can you differentiate by OCT between macular edema due to diabetes and that due to IV gas post-cataract surgery?
Okay, so, like I said, is that we don't manage OCTs, we manage patients. So I expect that you will have taken a history, and then you also remember that for diabetic macular edema, you'll be expecting to see microaneurysms. By the time a patient has diabetic macular edema, he would have at least microaneurysms. Sometimes there will be cotton wool spots, so which will not be present in Ewing gas. Ewing gas, the patient had a cataract surgery and then developed. Except the patient is a diabetic patient, now had a cataract surgery, and he already has microaneurysms and probably dot and blood hemorrhages, and now develops Ewing gas. That would be difficult to differentiate. But if he wasn't a diabetic patient, you look at the other things that are associated, because sincerely, cystoid macular edema and diabetic macular edema can look very similar.
Okay, thank you for that, sir. We have another question that says, what was the, from Dr. Ayo Harriman, it says, what was the presentation of the 35-year-old man with PED since his vision was 6'9"?
Okay, so he was actually sent for macular hole surgery. I remember him very well. The first doctor that saw him thought he had a macular hole and sent him for macular hole surgery. And of course, we didn't do anything. Sincerely, without an OCT, if you see that picture, you will be tempted to call it a macular hole without doing an OCT.
Okay, do we have any more questions from anyone? We hope to have this session at least once a month. We'll decide on the Wednesdays and we'll always circulate it. We're very happy that you were able to join us today. So if you have any more questions, please, we have 2 more minutes before we wrap up the session. Thank you. Okay, in the absence of no more questions, I would like to thank everyone for joining us. I would also like to thank Dr. Derilo and all who were able to join both locally and internationally. And then we'll let you know when the next lecture is coming up. Thank you so much. Thank you.
Thank you. Thank you. Thank you, everyone.
Thank you, sir.
Thank you, sir.
Thank you, Dr. Derilo. Thank you.
Thank you, Dr. Derilo.
Thank you, sir.
Thank you, Dr. Derilo.
Thank you.
Will the recording be shared? The recording, will it be shared?
Yeah, it's recorded, yes. Yes.
And it will be shared, yes.
It will be shared, yes.
Yes.
Thank you.
Thank you for the presentation. I was just wondering, maybe next time, if we could have the OCT, because we need to rush over it. But then people just hear these things inally listening outside. It looks very good. But then if we can just do maybe like take some 5-10 minutes and people just respond really what they can see. Is it really making sense? That's my suggestion. Because I know you have to rush over everything. Because if we can sit and really, once we are able to get the basics of the layers and where things are happening, and even with a closed eye, people can decipher where things are happening, they will be able to segregate CSR from PED with neovascularization and all of that. That's my suggestion.
Okay. Noted, ma. We'll probably it's just OCT is okay. We'll take it in smaller bits next time.
Yes, and then I think some of us, the optometrists, are doing the OCTs and they are really thoroughly confused. They'll just bring a machine to them. They don't know what they're supposed to see, how they're supposed to position the patient and all of that. So sometimes some of them will join in, and then when we just go all clinical, they get thoroughly confused. Thank you, sir.
Thank you.